April 5th, 2022, and we are kicking off the second series of AO Trauma North America Fireside series. And so I think before we get started, we just saw Mitch, but a quick and big thank you to Mitch Bernstein and Brett Christ for putting this on. I think this is their brainchild, and they put a lot of work last year and then even this year developing a whole new curriculum. I'll get to a slide at the end just showing the upcoming. We have 7 more kind of different intervals every week, every other week, but we'll see the dates at the end. And so this is on atypical ankle injuries. This is kind of a round 2. There was a session with Dr. Greg Berry, Dr. John Munns, and Dr. Brad Yu, who did an outstanding job about 8 months ago covering posterior malleolus and syndesmosis injuries. And so we'll kind of build from some of that, but we got to keep it fresh and keep it new. And so we're going to steer it into a bit of a different direction. And so when I say us, I think we're going to look at this crew for the night. I'm John Eastman. I'm here at UT Houston and Memorial Medical Center, Memorial Hermann Medical Center. And it's my privilege really to work with 2 of my colleagues who've been mentors to me since I was a resident and all through my AO career so far. And so I don't think they really need an introduction, but first we have Sean Nork, who is a professor at University of Washington and Harborview Medical Center. And then Dr. Matt Camuso, who's at Maine Medical Center in Portland, Maine. And so really just 2 incredible individuals, master surgeons, and really just world-class educators. And so it's great to have them. I'm looking forward to working with them on this topic. We have really no conflicts that are pertinent to tonight. They're all listed here just for full disclosure. And here's just a sampling of some of the things we're gonna be looking at tonight. And so I just want you to take a look and think about them. Give you about 30 seconds and just kind of scan the menu and maybe just think about what you see, what you're worried about, what tests you may order, what information you want, early treatment, definitive treatment. Because I think we're gonna get into all those topics. And I think, again, one of my biggest pet peeves in life, ever since I was a resident, was just the term, it's just an ankle fracture. These are all ankle fractures, right? But they're going to be incredibly challenging for a multitude of reasons. If you don't give it the respect, it's going to burn you, I promise. And so I think hopefully at the end of an hour and 20 minutes or so, we'll be able to cover these objectives. And so really just identify a lot of the key concepts for each individual and the whole topic at large in terms of what's critical for a good patient outcome. I think we're going to cover both osseous and ligamentous stability and why it's important. And then we'll cover current best practices and then evidence-based strategies for fracture care going forward. Tonight's agenda, very similar to the Fireside series in the past. We'll have this 5-minute intro, and then we're going to get into it. About 20-30 minutes for the first topic with Dr. Nork kind of leading. Although, again, in the spirit of the Fireside series, there's really no lecture. It's meant to be a kind of very informal, hopefully somewhat entertaining, but educational, and just kind of a low-key discussion about things we find interesting, questions we have, and we'd love to hear from you too. We'll have about 20-30 minutes on each topic. We'll come back and look at a journal article and then have a wrap up. And so again, about an hour and 20 minutes, and it should be plenty of time to cover. As always, the AO is a nonprofit entity. We're not promoting or endorsing any specific commercial device, and so we'll keep it very broad strokes. I think we're all fairly familiar with Zoom, although we did have a technical difficulty tonight. We'll try to keep those to a minimum. But I think the biggest thing here is the Q&A box. Again, right now there's 103, 104 people on. And again, the big purpose is for education. So we want to be here and have interaction with you as much as possible. Even though you are camera off and muted, we do want to hear from you. And so hammer us with questions. I'm going to do a big effort to try to poll as much as we can, but then to scan that box and make sure we answer questions either with discussion or we can type them back and forth and have that dialogue. And so please use it. It's there for that. There will be a link for this if you have to step away or you want to watch it again in the future, because it'll be your favorite thing of all time. It's on YouTube, and again, you can search it or you will have the link sent to you. And so with that, I'm going to turn it over to Dr. Nork, and we are going to get going.
Thanks, John. Let me share my screen here. And it is great being with Eastman and Camuso, talking about ankle fractures, and hopefully this will be fun. I'm going to start with just, when ankle fracture is not so simple, even though at a glance, I think this case, which we'll get into, looks relatively straightforward, and I think it'll hopefully give us an opportunity to talk about maybe an atypical injury pattern, and then we can maybe get into some of the details of how to make this ankle fracture right. So nothing tricky here. So it's just a 22-year-old after a motor vehicle crash. And the only reason I put that in there is I didn't want us to get off the rails a little bit and talking about swelling and external fixation and stage management. I really want to just focus on the fracture pattern, and we'll get into the principles of treatment. And so I'll kind of turn it over to Matt and John just to comment on what first catches their eye when they see this injury pattern on the plain films alone.
Yeah, I can start, Sean. I'll start. You didn't teach me any of this stuff, so I'm just going to tell you what I learned after I left there. But one of the things I like to try to do is look at an ankle fracture and see, in what direction it failed, right? So, and to do that, I classify it. So I didn't learn a lot of classification when I was in training, but I find that classifying it, forcing myself to classify it, makes me understand it better. And so when I look at this, it looks like the talus has loaded the medial side of the ankle and caused a fracture that's vertical, pushing that medial side of the distal tibial plafond upwards. And in doing so, it looks like it's also impacted the most lateral side, most medial side of the lateral articular surface where you have your arrow right now. And also maybe in the shoulder, it looks a little funny there to me. The shoulder of the medial malleolus looks sort of perfect. I mean, it looks nice and congruent there, but it sort of looks extra long to me for some reason. So I also look at the comminution that's present at the cortical surface. We always like to have articular fractures where the cortical reed, when it's simple and perfect, represents an accurate articular reed as well. And since I think I might have some impaction at the medial side of the medial malleolus, as well as a imperfect or a comminuted cortical reed there, it's just going to make it harder for me.
All right, good. I think what you've kind of identified, and we'll go into looking at some of these details, are the features of these. And look, I think this is no mystery to anyone that these get called supination adduction ankle injuries. And there's been a lot of interest in these of late. I just quickly, I went to PubMed last night in anticipation of talking about this today, and three people that I really respect a lot, that were all previous fellows here in Seattle, have all written manuscripts on these just within the last 3 years. There's one that Heather Valier and folks had written out of Ohio. Justin Halloran, with one of my current partners, Mike Givens, had written out of with the Utah gang, and then Jeff Marisek down in LA had also. And I apologize, there were a lot of co-authors on there. I don't mean to leave anyone out, but there is a lot of attention to this, and I think it's for the reasons that that Matt was outlining is there are a lot of little subtleties that are kind of the difference between perfect reduction and, ooh, I'm not so happy with that. John, you getting a CT on all of these when you see a supination adduction ankle injury?
Yeah, I think so. I mean, I think, everybody sees some of that impaction, but I think the CT shows you that plus more. You're going to get a sense of what is that shoulder piece, how free is it. You're going to get a sense of where this combination is, anterior to posterior. And then like Matt was saying, I think when you have that apical comminution, you're going to be able to anticipate where are your remaining cortical reads that you can work off of. And so you'll get a sense of all those details from the CT. And so I think 100% everyone gets a CT.
Matt, same CT on all?
Yeah, I think so. I mean, I'm in a place where sometimes I show up and the person's like on the schedule doesn't have a CT, so I'll have to work through it. But those are days that I'm unhappy. So my preference would be to have a CT scan of this for sure.
Oh, and by the way, fill in things on the chat box for the participants as we go through, and we'll address them. Either we'll type you an answer, or we'll answer it as a group. So just to not belabor it, these are the axial images, and I think it shows, this is cranially, just some of the cortical comminution that Matt mentioned, but we've got a nice fracture read that we'll have anteriorly where we're looking. And then as Matt identified, you can see, in that medial shoulder area, but I think more telling is going to be the coronal images that will show that upslope that you see on the medial aspect of the plafond. And then, Matt, what do you think? Are these still ankle fractures to you? Are these plafonds, or are these kind of transitional?
Yeah, I mean, I guess we used to call them sort of trainee pilons, right? Like baby pilons, because there is an axial loading articular impaction component to it. I guess technically it's an ankle fracture because it's the result of a bending load, but the bending load is so severe here that it causes that marginal impaction. So it's a transition for me, I guess.
Yeah, I think I heard Mitch call it a pilonette one time. I thought that was pretty good, even though it's, I still like
the French version. Sure.
Matt kind of mentioned this, and I really, for the participants that are on, I don't want you guys to think that we spend all of our time like obsessing about irrelevant aspects of a fracture, but I can tell you this little tension failure fracture line that you see right here is the most annoying. This part, which you've seen a lot of these, all of a sudden now this is the part that you know exactly what to do with, and we'll talk about the details of that. This is the part that I find to be really annoying because that tiny little gap translates into rotation of that. So you've got impaction on the medial malleolar side, and then the obvious impaction on the intact tibia plafond side. And unfortunately, we gotta address both. Matt, you having bone graft on the ready?
Will I have, you mean allograft? Yeah.
Yeah. Do you have allograft? Do you use a calcium phosphate for these once you've elevated on this part of the joint?
Yeah, for me, it's cancellous allograft. I don't use a lot of calcium phosphates. I find that the cancellous allograft works well if I can pack it in the way that I need to. So yeah, we'll have it ready.
What about you, John?
Yeah, I think either or. I mean, depending on bone quality and stuff, I think allograft is always there and hopefully available if the person's willing. But I think autograft locally in the fracture bed or even higher in the tibia are definitely options as well.
I skipped the fibula on this particular one when we were talking about it, when Matt kind of described this as really a kind of a bending moment around the intact plafond. And so you get the obvious compressive failure, bone with comminution, impaction, where the talus impacted the medial malleolus to create that vertical fracture. And then I think everyone can appreciate that we've got tension failure of the fibula. So this is kind of the start of a varus pilon. So what that creates, though, is a really simple fibula fracture pattern, which I think opens us up to some other options for treatment of a fibula. We sure don't need to put double locked plates on this fibula. Matt or John, why don't we start with you? What are you usually fixing the fibula with on this simple tension failure?
Well, I think it's interesting too, also that we can get into the sequence. I mean, because I remember trying one and we got so focused on some of the comminution we're talking about. And so we kind of, the fib was barely displaced, during initial treatment. And then we just kind of ignored it for a while. We started working on this and we started elevating and doing stuff. And then we took an x-ray and the whole talus was subluxated. And so we were getting a false read, because the talus wasn't in the correct position because we didn't address the fibula first to kind of tether it to where it's supposed to be. And so I think I've learned my lesson to always pay attention to the fibula, even though it's simple, even though it's kind of just sitting there. And I think depending on the bone quality, sometimes that's just an intramedullary screw that can be one long, like a 3-5 or even a 4-5 if it's amenable, but the head's a little bit big, or even smaller, maybe 2-7 screws that are off axis to try to get that. But I think some of those, if you just have one point of one point of fixation, there can be some rotatory instability, and so I've had good reductions that don't sustain during the rest of the procedure, and so oftentimes it's augmented with some sort of mini fragment plate with limited fixation. I think it's small caliber but appropriate.
I think those are all kind of good points on the fibula. It does look like it should be the biggest chip shot known to man. I have a little sequence for those we'll kind of talk about, but I think important thing is it's amenable to intramedullary fixation, but it probably needs to be, like John said, a screw, not be tempted to just put up a titanium elastic nail or something that doesn't actually compress that tension failure on the lateral side. Matt, are you a plate or screw, or just depends upon your mood?
No, I have done the screw before, but I'm never satisfied with it. I don't get the compression that I want. I get rotational abnormalities with it. And so I make myself a little hook plate and kind of get it on the end of the fibula, and then actually use a push-pull screw to sort of tension it, and just use a Fibrouge with a push-pull screw and just bring that hooked fragment distally, proximal, and then load it. And then I just know that I got it captured and it's done. And and then it indirectly reduces the talus so that I don't ever have to worry about it doing what John said, which is interfering with my articular reduction of the plafond. So I start with the simple part first, just like you brought us back to, which is just get the simple thing done out of the way first, and then you can spend all your time on the hard part.
Sounds good. Let's just look at a few details. So I think, as Matt described, tension.
Hey, Sean, quick question though. We have a question from Marshall. The question is, are you always opening the fibula, or do you ever consider a percutaneous screw if it's truly non-displaced, if the soft tissue is swollen, there's some blisters or something in that area? What do you think?
Yeah, so I'm buying what they're selling for sure, because this is the pattern with a varus failure, where if they haven't been splinted, sometimes they do come in with not great lateral soft tissues, and so I think having a minimal approach or not opening that is reasonable. That being said, I can't think of the last one where I was not able to open it, and I don't know if it's just because we're getting early reasonable closed reductions, but I've always seen these where I could feel comfortable opening them. But I think it follows principles.
I agree, Matt. Same thing.
Yeah. I mean, if it's non-displaced, then I'm going to try to hold it there with something simple. And so I'm not averse to using a screw in that setting. But having said that, I've definitely displaced it by putting a screw off axis in doing that. So you got to be right. You got to be careful. And as you said, the fibula has to be amenable to it. You know, some fibulas are kind of shaped like this, and so if you start at the apex of the fibula and you're not right, you know, in the axis, then you can displace it. So I just would be careful of that.
I think one final point too. I think there's just like the medium malleolus. I think sometimes the periosteum kind of gets, you know, sucked into the fracture line sometimes, even though it looks like it. And so I have been surprised with any sort of limited intervention. There's still some sort of tissue or something that doesn't allow full compression. So I think it's just easy to get fooled sometimes.
Yeah, I mean, to your point, at one point this fracture was like this, right? It didn't just do this. It was like this, and what we're seeing is it sprung back into that position. So clearly, you know, it's an unstable piece, and as you said, there's likely material inside there that's going to make it hard to compress.
And I've noticed that when I do put in I usually fix these with plates, just personal preference, but when I do fix this with the screw, I usually start the screw there. I don't know, my brain just tells me to. And it seems like when it engages the canal, it gives it a natural, unfortunately, varus bend to the screws. So it wants to actually accentuate the deformity when I get it wrong. I don't think I've ever put a screw in with a starting point that's too medial. I always put the screw in with the starting point too lateral, so it introduces varus to it. So I think all that to say, if someone's using a screw, just be careful that you're not off axis and that you're not accentuating the deformity that you're trying to prevent.
Great point.
Okay. So I think everyone sees the impaction, sees that annoying little fracture line that I kind of mentioned. You know, I always look at this one as analogous to the little fracture line at the elbow that you see that separates the medial epicondyle from the trochlea. You can barely see the line, but if you can see it, it means it's off. And so that part is annoying. So I did open this, and this is my usual. Everyone kind of has their way, but just put a drill hole in and have a modified clamp. And I figure if this failed in tension, now I compress it on the lateral side and then put on a tiny little plate that's just like a little clamp, probably a waste of time. I'm clearly bored in the operating room, so I think around. Put on a little plate that's on the tension failure side, and then put on just a slightly more robust implant so that it controls rotation. That's probably overkill for this. I know a lot of people, a lot of the 139 participants are thinking, I would just put a 3/5 screw up and move on, and I get it. But I do want to make sure that I start so many surgeries and my first move is my first malreduction that then amplifies for the next however long I'm operating. So I want to make sure that I take a simple fibula and get that right.
I think
as you said, if it's
go ahead.
If the fibula is in varus, you're going to be fighting it the whole time, right? You're going to be trying to push the talus over. And if you fixed it with the fibula in varus, you'll never be able to get that proper reduction at your plafond. So it is really an important part of this case, actually.
I think one question I think about sometimes, and I've heard different answers. What do you guys think about just getting contralateral films? Let's assume this is a isolated, extremity. Their other side is normal, as far as you know. Are both you guys getting contralateral films to compare against?
I'm going to check the participant list and see if Benershka is on there. So if Steve's on there, yes, I always get contralateral films. If Steve's not on, I'm like, yeah, I usually forget. And then if something's not looking right, I'm trying to fluoro intraoperatively. That's the reality. On C-type pilons, then I really do get contralateral films, but on something like this, I don't. I should. Matt?
Yeah, I don't on this either. But I do try to do it on, you know, ankle fractures, some of which I'll show where, you know, I have to be sure that the syndesmosis is reduced properly, which means I got to know what their mortise looks like. I got to know what their fibular rotation looks like. I got to know where their fibula is in relation to their tibia on the lateral views. In those situations that I don't think that we need to know those things for this case. And so for me, I wouldn't get one on this one.
All right. So this is my go-to on these. Distractor, Matt, or do you feel like you got the fibula right? You've got the talus shifted back. You can get a pretty good judge of where the joint elevation should be.
Yeah, this is one where I don't think it's necessary really, because I can really see it, and I'm using the talus kind of as a, you know, platform onto which to reduce this fragment. And, you know, I'll probably do it 3 or 4 times until I get it right, like many of us do. And if I still haven't gotten it right after the 3rd time, then I might put the distractor on to make sure that I'm getting it down as far as I need to. But I wouldn't start with the distractor necessarily, because I just use the talus as a guide to, you know, how far to bring this articular surface down.
You know, the part I skipped was just this screw's kind of a little in to out screw, if that makes sense, to fix that annoying little rotated fragment that's impacted. I usually rotate it out, and then I tend to put a screw kind of in to out to hold it. That better be right, because I'm folding that closed and I won't see that again. And then this is just an osteotome. This is just a simple curved osteotome, usually right about at the level of the physeal scar, that I go into, and there's just an image on that patient. You can see just that kind of in to out screw that fixes that in the osteotome going in to bring the joint down, which leaves us with a little bit of a gap, appropriate. And I think what you all talked about, depending allografts, packed, I think works. Calcium phosphate, very reasonable. What I've been doing of late is, you can see that hole. I took the picture a little late. This is another old Benershka, you know, taking bone from the calcaneal tuberosity, but in this case, because you've got so much exposed cancellous bone and it's not going to affect the reduction read, just take some bone with a drill sleeve, and then you get a nice little dowel that seems to be the perfect size for that impacted area, for the gap that's left behind.
Sean, how do you determine how high up to start with your osteotome? I mean, I assume the higher up the better, but you went up 5 millimeters or a centimeter. How do you decide?
Yeah, I look for a fault line, and so if I can find one with a little freer, that's where I'm going, unless it's right next to the cartilage. And then if it's unclear because it's stall impacted, I try and do it about the physeal scar or higher, just so it leaves me enough bone on the elevated articular segment. That's with graft in, and then you know, I think like with everything fracture wise, I say this all the time, I'll say it again, it's easier to hold a reduction than a malreduction. So I think if you've got that then well reduced, you don't need, I think, a lot of implants on the medial side. You just need to principle based anti-glide. John, do you have a kind of a go-to size implant?
Yeah, I think for a lot of these, you know, the vertical nature, I mean, I think that principal base it's begging for a buttress. And I think depending on the size of the bone, I often go for a 6-hole kind of quarter tubular plate, either 1 or 2, depending on the size of the person and or the fragment. If it's really large, maybe it's a 1/3 tubular, but it's it's usually not anything bigger than that. But I think just like you said, you're getting the work of the implant as well as the screws holding it.
Matt, same small, low profile implant principles.
Yeah. Yeah, I will say though that I've had a couple patients with diabetes that I have done that for, and they have failed catastrophically. like not even, I mean, just really, the worst. It's awful. And so I think that that's a mistake in those people. I think that they need more robust fixation, because they just the plate just fails in that patient population. And so for me, I'm doing the same thing for the diabetic patient. I'm going to use good soft tissue technique, but I'm going to do all of the things that you did here to make the joint right. But in that case, I would use a little bit more of a stout implant.
That is a great point. All right. So anyway, that's it. You can still see the path of the old, where we took the bone graft from, moved the bone there, and these are just a couple of 2 millimeter non-locked thumbs acting as buttress and giving it rotational control. So anything else on supination, adduction, ankle injuries, John, Matt, that you can think of that we didn't touch on?
Well, I think there was a question in the Q&A box that's kind of going back to the fibula. It was asking for how are you judging your reduction on your fibula radiographically, and then I think you mentioned it, but just maybe you want to hit on the concept of why you had that second plate for this example.
Yeah, for me, it's more a sequencing thing, that if I've put on that clamp that's directly laterally, that compresses it laterally, I just want to hold it there laterally with a very low profile implant. And then I put a larger implant. It's still just a third tubular plate on the back. And I think it gives a little better rotational control. And that way I'm not having to take a third tubular plate on this relatively distal fracture and trying to get 2 points of fixation distally to get rotational control. So that's kind of why I'm doing it, but it's just a personal preference. I mean, we definitely don't need to be double plating fibulas, but it's more just for me, just sequencing of clamps in the way and then not having plates too distal, especially posteriorly.
Sean, you showed us, but can you just describe your exposure for this?
Yeah, so on a lot of these, I do them like a full anteromedial pilon exposure, just because of the safety of closing those, and so I don't find myself getting into trouble by saying I'm just going to take my usual medial malleolar approach and just extend it proximally up the anteromedial face as needed. Now, I think that works and it's fine in the vast majority of circumstances, but for me, just moving the incision over and doing a formal anteromedial, I don't mind the extra time for closure of that, because then I know it's going to be fine.
I think it gives you a better visualization too from front to back, right? I mean, you're looking from the front down the back, you can see right down the path of the fracture line, and you're not having to look over the top or around the front of that that dominant shearing malleolar fracture. So it's the same way that I do it, a true formal anteromedial exposure.
Yeah, that's a great picture too, of just those the cortical reads you're going to see. I mean, I think again, the priority is the joint and getting that right, but in assessing your kind of indirect reduction of when you shut the door finally, you're having those nice clean reads, even when you have that apical comminution. So it's a great example of why to be upfront.
Yeah, because that's my usual sequence is reduce the medial side, see how mal-reduced the joint is, take it back apart, elevate the joint, re-reduce it, still mal-reduced, and kind of keep repeating that sequence until it's right. All right.
And then I think final question was just weight bearing status. I mean, are you treating these like a pilon with 3 months? Is this a 6-weeker? Is it somewhere in between? How do you make that determination?
Yeah, so if you look at results of these, the results compared to torsional ankles is like something in between. They're not quite as good as torsional ankles. They're probably behaviorally more like partial articular pilons. So that kind of drives me to treat them more like pilons. So I hate to say it depends, but I'm definitely not a 6-weeker. And so depending upon how much articular comminution there is, and how much joint elevation, I may take them to a full 12 weeks, which is what I do for pilons with no evidence of that. And if it's a little more mild version, maybe I'll do 8 or 10 weeks.
Matt, same?
Yeah, I treat it more like a pilon for sure. Absolutely.
Great. Sean, that was a great case. I think, Matt, you're typing an answer, but we'll transition. We'll start that second one. I think as he's doing that, I mean, Mohammed talked about, should we worry about a deltoid ligament injury in this pattern? I think we're going to get into some focus on that ligament. But Sean, I mean, do you worry about that? You see that exposure, you're looking right at that. Are you ever focusing, thinking, seeing that?
Yeah, so I worry about everything because that's who I am. I'm an anxious individual. But in this pattern, the deltoid usually shortens with that classic varus failure. So I've not seen a deltoid ligament injury with this pattern. But I'm always thinking about it.
I love it. Me too. Matt, we're on time. Let's go.
Great. Can you guys see my screen?
We can.
Perfect.
Super. Mohammed, I'm glad you asked that question because we're going to talk a little bit about this. So, this is entitled Atypical Fracture Management because I'm not sure I'm going to show any really truly atypical fractures, but I may show you or at least challenge you to think about how you fix these fractures currently and perhaps help you understand that there may be some other ways to manage them. And I'm going to try to follow on the heels of what was presented back in July. Again, like John said, there was a great webinar done just about 8 months ago by Greg Berry and Brad Yu and John Munns. And they focused primarily on post-gemmelar fracture patterns as well as reductions and assessments of the reductions of the syndesmosis. And they got into a little bit of what we're going to talk about today, but what I was struck by when they were concluding their session was, man, it's hard to reduce the syndesmosis, and you got to use all your different tools to make sure that you're right. And even when you do that, sometimes you're wrong. And so it makes me wonder: is there another way to do that? So we'll go through that. I started out by saying thank you, Mohammed, for asking us the deltoid ligament question, because if you force yourself to classify these fractures, you'll answer that question, right? So this is the only ankle fracture classification that I learned when I was a resident. It's the Weber classification, and it's the A, B, and C, right? The infrasyndesmotic, the transsyndesmotic, and the suprasyndesmotic injury. But as I finished my training and started doing ankle fractures on my own, I started seeing patterns that, of course, had been described before, and now I really force myself to look at ankle fractures and force myself to put it into one of these 4 categories. The Logie-Hansen classification system, although imperfect, is still a valuable tool, I think, for those of us that are routinely fixing ankle fractures. So on the far left of your screen, you'll see what we just did, the supination adduction injury. And you see in that the stage 1 is a fibular avulsion fracture, or sometimes just an avulsion of the fibular collateral ligament. But on the medial side, it's always a vertical fracture. It comes with articular impaction, but there's not really a deltoid injury. So you should not expect that for these injuries. However, there are all the other three categories are fracture patterns that may have deltoid ligament injuries. And so you're right to think that that is part of an ankle fracture and is something that we should pay close attention to. So we're going to go through a few cases. We'll get through as many as we can, and we'll talk about some different strategies for how to manage these injuries. So, John, this lady, of course, is a competitive dancer, because whenever someone breaks their lower extremity, they're either a marathon runner or some sort of dancer, and she is that. And she's also a dog walker, and she fell and has this injury. I guess I'll start by just asking you, what do you see, and how do you think about this injury as you start to plan for it?
Yeah, I think I'm following suit, just like you did on the first case. I think, I'm looking at her soft tissues. I don't see any open indications or air. I think that you can see your fibula. It's shortened, and it's looking like it's slightly displaced. There's wide displacement of her incisura, and so it's indicative that some sort of displacement and disruptions happen there. I think going back and forth between the lateral and the AP, you can see there is a posterior malleolar fracture fragment that you see. You can kind of highlight that. There's a small piece of comminution. I'm not quite sure where that's coming from yet, whether that's fibula or maybe the apical part of that posterior malleolus. I'm looking at the medial shoulder. I see kind of a hint of a fracture line. I'm not quite sure if that's real or if that's just kind of the rotational view. I'm looking at her talus to see if I see any big osseous lesions, or just maybe anticipating where some of that chondral scuff is going to be. And I'm looking forward, I think, again, just like Sean asked, I think I'm my early treatment, but then I'm wondering what the CT is going to show me and how I can plan how to best take care of it.
Super, that's great. Sean, anything to add? Actually, Sean, tell me what the log enhancement classification is for you.
So this looks like it's going to be, if I were a betting man, it's probably supination external rotation injury with a high fibula with disruption all the way around the ankle joint. I know when the fibula is high, we're supposed to think pronation external rotation, but I'd be surprised if that's what this was, right? The classic SER pattern is a Weber B fibula associated with posterior malleolus and medial sided injury as you progress. But I think you're suggesting I should be going PER with the high fibula.
Yeah, more importantly, what's injured?
Yeah, so like John said, the widening of the syndesmosis with the associated posterior malleolus, which removes the integrity of the posterior tibiofibular ligament. If there's no fracture on the medial side, there's a deltoid ligament injury. And then there's a little bonus piece of bone that I just can't tell by looking at it right now, that's sitting there kind of in this incisura on the fibular side, that could represent osseous avulsion from either the Wagstaff-Lefort portion of the fibula, or it could be from anterior tibia. So putting it all together, fibula fracture, syndesmotic disruption, posterior malleolus, deltoid, and anterior capsule.
Super. Okay, John, take us through how. So we don't have a CT. I'm not going to give you a CT here just because for lack of time. What are the priorities here for you in terms of reduction and fixation, specifically with regards to sequencing? What are you going to address first? What are you going to address second? And then how does that help you with your pre-op plan, positioning, approach, and then fixation strategy?
Yeah, I mean, that's a whole hour and 20 minutes we could talk about that thing. But I think Just like you thought, I'm looking at the failure mode, and like many of these, I'm thinking about it failed coming laterally in terms of the site of instability, and so I'm going to have something to reestablish the lateral column. And so I'm thinking I'm going to start either with, depending on what my CT shows me, because again, I think just like the past Fireside one that was done 8 months ago, which just showed us for the posterior malleolus, understanding kind of the morphology of that will help you determine how you can fix. And so understanding the subtleties of those fractures, I think will determine first versus second. I think oftentimes the posterior malleolus is first. I think sometimes when there is comminution and I really can't trust those reads, I will fix the fibula first, depending on where the adequate or the anatomic reduction read I can get. And sometimes you sacrifice a little bit of that articular reduction that tends to be blocked with the fibular plate. But I think, for this, you can see the size of the malleolus. It's not so much a articular injury, it's more so the ligamentous attachment is the important part. And so I'm not really concerned about not being able to judge that articular read, because again, that's not the big focus for this one for me. And so I think, again, sequence is, well, you talked approach, it's probably prone, posterior lateral, looking at both of those sites depending on the CT reads, and then assessing after that whether syndesmosis has been reestablished by reestablishing the PITFL attachment, and then looking at the medial side last.
I've heard people say all the time when there's a posterior malleolus fracture that we got to fix the posterior malleolus first and then address the fibula. Is that true all the time, John? Or why do people suggest that? Is it wrong to fix the fibula first here?
Is that for Sean?
Sure, Sean.
Oh, okay. I thought you said John. No, I don't think it's wrong, especially on this. And I know you're not going to give me a CT because you said you weren't, but that actually may influence that. So if there are little joint mice in there that I need to get out in order to accurately reduce the posterior malleolus, then I'm definitely not going to fix the fibula first so that I can accentuate this deformity intraoperatively, so I can clean out those little mice that may block the reduction. And then on those, I'll insist on doing posterior malleolus first. But if those don't exist, and it really is just a osseous ligamentous reattachment, then sometimes fixing the fibula first will help position the posterior malleolus and make that component of the surgery easier. So that is a case where I will stare at the CT a bit, and it'll influence my order. In the vast majority of circumstances, I go posterior malleolus first, though.
Okay, that's super helpful, actually. I think similarly. So we did have a CT in this. I don't have it to show you, but there were no articular fragments. It is purely sort of an avulsion fracture of that PITFL that is a bony extra-articular piece of the posterior malleolus. And so we thought about it the same as you, and this is sort of what I thought. So I looked at this injury and said, okay, we've got injuries to the medial side of the ankle involving the deltoid, the capsule in the front and the back, the anterior AITFL, the fibula, and then a posterior malleolus. And so from a bony standpoint, the only things that I have that I could fix are the fibula and the posterior malleolus. And so for me, I also am anticipating that I'm going to have to do some other things here, right? So that may not be enough to get this ankle stabilized. Who's John? What are your thoughts? Are we going to have to instrument this syndesmosis, do you think?
Well,
because that may
may
determine how you position the patient and how many times you flip from prone to supine, right?
Absolutely. I mean, I think you're kind of robbing Peter to pay Paul a little bit, but I've just found so many times trying to do posterolateral work, supine or even lateral, I'm sacrificing and kind of working upside down to try to get back there. And I think, again, when there's fragments of bone, reduction reads are hard, and I think I'm hindering myself more than helping by trying to save a flip. And so sometimes I'll just commit to a prone, most times, to make sure that I get those reduction reads perfect. Because I think, again, the question of syndesmosis, I think, I've definitely learned since coming out of fellowship the importance of it. And I think we're all starting to recognize that now in terms of the ability to indirectly reduce the syndesmosis by reattaching the osseous footprint, like Sean said. I think saves a lot of time. A lot of the times you don't have to place syndesmotic fixation, nor go through a reduction sequence and potentially induce an iatrogenic malreduction by incorrect clamp placement or vector or some other problem that we're doing when we could just solve it by reestablishing normal anatomy in the first place.
Got it. Yeah. Have you ever tried to reduce the syndesmosis prone?
No, I think the times that I'm
Just
prone
flip it.
because I'm going to the back part of the ankle. And so I've never, as we talk about this more, I've never done like a purely ligamentous repair. It's always been attached to a osseous footprint. So I've never done that because I think as a bailout, if the radiology reads and all the things we're looking at aren't right, I then have the ability to do an open reduction from that, which I think is obviously challenging when you're prone.
Well, let me show you what I did. I agree with all of the things that you guys have said. It is no doubt easier to access those areas when you're prone. However, it is, I think, in my mind, very difficult to do the stress examination of the ankle in a prone position to identify residual subtle instability. So for me, I actually prefer to do these supine, and I understand that I'm going to be working upside down to some degree to address that posterior malleolus, and I get it, and I have tricks to optimize that. I put a really big bump underneath their side. I make sure that their hip can externally rotate properly. I have help in the room that helps me internally rotate their leg. I can sort of airplane the table, if you will, to be able to get to the back. So I have ways to get to the back, but I am still supine, and so it helps me with my imaging. And I'll just show you in radiographic terms why I do that. So here we are with this patient, and we've dominated this fibula, right, Sean? I mean, this fibula is completely dominated.
Now you're talking, Matt. I like it. I like it a lot.
It is good, right? So, but here we are, and we haven't fixed the posterior malleolus yet, but we understand that fixing the posterior malleolus will give us some stability in terms of reattaching the posterior and inferior tibiofibular ligaments, and will provide some syndesmotic stability. So as you might expect with a stress view before fixing the posterior malleolus, there's your radiograph, and we still see obvious lateral talar subluxation as manifest by medial widening of the clear space. So what next? I mean, we talked about this a little bit. John, you described the challenges with clamp reduction and how that can be inaccurate by over internally rotating the fibula, or in some cases externally rotating if the clamp isn't perfectly on axis. Direct reduction with screw fixation of the syndesmosis would be hard to do if you were in the prone position. Fluoroscopic reduction with a clamp, and then flexible fixation. All of these are choices, but I think maybe I'll speak for the both of you, Sean and John. You both suggested that posterior malleolus fixation would be important here, and so I think that that's probably the next thing to do. Was that what you would both do? Good, yeah. So that's what we did here, and again, even though I'm in the supine position, someone in the chat has suggested that I should just go lateral decubitus. Absolutely, that's pretty much what I'm doing when I'm supine. I have such a big bump underneath their backside that they're almost lateral decubitus, and so you're right. Doing a lateral decubitus is actually a good idea in a lot of these, as long as they can externally rotate their leg well enough for you to access the medial side of their ankle. So thank you for posting that comment.
Hey Matt, real
So
quick
here we
on
are.
that. If you find someone who's got a stiff hip or something like that, have you ever put them supine and done the bump and done the test, and then you're like, I can't do it, and then you end up going
Yeah.
prone? Or can you figure out a
Yeah.
way with your tricks to make sure that you can do that?
Yeah, I've learned the hard way that way, right? So I've identified a stiff hip and said, oh, it'll be fine, and I've just gone ahead with it and struggled really way too much. And so those are the ones where I'll just actually go lateral, so so that I can still get to the back, and then I'll just turn them supine when I have to examine them. Usually I'll use like a bean bag and position them lateral, and then get the fibula and the posterior part of the ankle fixed and stabilized. Then I'll deflate the bean bag so that they can roll into the supine position, that then I can examine them more accurately. So that's just my way of doing it. Okay, so here we are. We fixed the posterior malleolus, and it's a reasonably accurate reduction, we think. But when we stress it here, we still have some subtle instability. So what next? What's the next move, John? What do you do here? You're prone, by the way.
Well, then I'm under my breath. I would never say it out loud, but I'm saying some not nice things to myself, because maybe I should be in your camp and have access. Or I just realized my day got a whole lot longer, because again, I think we're realizing, and I think we'll cover it later, that the deltoid is important for this. I think we have our syndesmosis there. I don't see a whole big change in the tibiofibular overlap, but I am seeing some increased clear space and maybe some tilt. And again, I think you said it's subtle, but I think you can appreciate the difference. And in the game of millimeters, I think that will make a difference. And so again, when people have talar tilt, even with rotation stress, or even sometimes plantar flexion, I think that is the indication to think about deltoid fixation.
Sean, any other thoughts?
Yeah, just a few. One is, I think when you have an injury like that, which is effectively a fractured dislocation with the amount of syndesmotic injury, I know I'm fixing the posterior malleolus. Then if you tell me, though, there are a few things that I can't do. I can't do prone. I have to be supine. One is assess the syndesmosis and stabilize it. I'm just too uncoordinated to do it in prone or lateral. Two is anything with regards to the deltoid. I got to be supine. I cannot do that upside down. And the medial malleolus. So if it's truly extra-articular and no joint mice, then I'm doing supine big bump all day just for that reason, because I'm betting large. I've got to do the posterior malleolus because this was a fracture dislocation. I've got to fix the fibula, and I'm going to have to assess the syndesmosis. And in this case, then I'm fixing the deltoid all day long, and then reassessing with stress exam number 3 on this one. So fibula, posterior malleolus, then deltoid, and final stress exam before we have the painful conversation about the syndesmosis.
No, that's great. I mean, I did you always do that, Sean? I mean, were you always a deltoid fixer, or would you get this? Would you get this X-ray and say, "Zip, I'm doing transsyndesmotic fixation"?
Yep, all day long. That was, we never, I didn't start fixing the deltoid until Milton and Dean and the HSS folks told me I should, and even then I'm a slow adopter and a slow learner. And that took a while, because I was always taught, don't fix the deltoid, it'll scar in. But I was putting in syndesmosis screws and having that lengthy conversation. But I have, I'd say over the last 3 to 4 years, I have converted to fixing the deltoid much more frequently.
How about you, John?
Yeah, it's the exact same thing. Just the evolution of kind of benign neglect. You're just kind of putting over in their corner and not really paying much attention to it, thinking it'll scar in. And I just saw like an interesting paper, just like Sean, just kind of looking at different topics. And there was talking about just the interposition of a deltoid that's there. And so Sure, it can scar in, but it's in the wrong position, and who knows long term what that's going to mean for someone's ankle. And so I think, again, I've learned to kind of have more curiosity for it and more respect for it. And so I think it is something to pay more attention to.
So this question is answered, right? I mean, we used to ask these questions all the time. You know, what's the next move? It's got to be some way to stabilize the syndesmosis. But I think you guys think about it the way that I do, which is if there was a fibula, if there was a medial malleolus fracture there, you would all day long fix the medial malleolus if it's stressed and it was unstable like that, right? That would be your next move. And yet for some reason during my training, and for a lot of the participants, I'm sure they were trained that in that case that we have, that you would put syndesmotic fixation in instead of addressing this area, which instead of being a fracture is a avulsion of the deep and superficial deltoid in this pronation external rotation exam. So I was late to come to it too. And the only reason that I ever really did it was when I saw patients like this that came in with this classic open medial sided tension wound, and the medial malleolus is sticking out of the skin, and the dissection's done for me. I'm looking right at it. I can easily fix that with suture. And when I did that, I realized that it worked well. And so I'm also reminded by one of my partners who used to scream at us and say, the deltoid is bigger than the ACL, and they have a whole industry about fixing the ACL. And so I didn't listen to him for a long time, but you know, in this particular case, here we are, and we've got, you know, instability. So a curvilinear incision made over the medial malleolus shows you this. And so the T is the talus. This is the heel, and then up at the top left of your screen are the toes, and the leg is towards the right. And so what we see here as we zoom down in is a couple things. So here's the medial malleolus with the deltoid ligament still attached, in this case, to the medial malleolus. What you see is chondral injury to the medial malleolus articular dome, which is, in my experience, almost universal with these injuries. There's always a scuffing and oftentimes full thickness cartilage loss off of the dome of the talus here, with the resultant articular fragmentation in the joint that needs to be removed and washed out. And so this is your opportunity to do that. And for those of you that are looking for you know, a specific technique about how to fix the deltoid, anonymous attendee with the question at 8:58, I refer you to this article. It's a good article by Mike Gardner and his colleagues in the Yellow Journal back in 2001, edition 29, where they go through reasons for and reasons for not fixing the deltoid. I think in the paper they come to the conclusion that in most cases it is advantageous to fix the deltoid, especially for cases like this, where it helps stabilize the ankle and obviates the need for syndesmotic fixation. And it also goes through a nice technique for using suture anchors to repair the deltoid. I simply put a suture anchor in wherever the bare spot is, whether it's in the talus, which is less common, more common in the medial malleolus. I'll freshen that area up with a rongeur, and then simply put the suture in a sort of horizontal mattress into that stump of tissue that is remaining, and adduct or internally and invert the foot, and then tie it down tightly. The second thing I think is important when doing this is also repairing the anterior capsule, because I think that's sort of like a pants over vest or a belt suspenders repair to the medial side of the ankle, helps prevent that external rotation instability. And so this is what it looks like after fixing the deltoid and the anterior capsule when external rotation stress is applied. And so we have created stability of this ankle without instrumenting the syndesmosis, which I think was you know, the goal to begin with. Do you guys have other comments about that case?
Yeah, Matt, I do, and thank you for bringing it up. The bit about the anterior capsule, because on these, for them to have that much of a displacement pattern, and I know it's written and it's well known, but you just don't think about it. I mean, okay, now we're biting on the deltoid, but I find myself routinely suturing the anterior capsule as well. Usually not to save costs. I don't put a second suture anchor in for it, but I do use a double-armed suture anchor if it comes off the medial side and not off the talar side. It seems like it's about a 2/3, 1/3 split. More
Right.
frequent off the medial side, but I'll use you know, a 4-needle anchor so I can put sutures into the anterior capsule and pull that over as well.
Yeah, no, I'm sure our sporty participants know what that's called. I don't know what it's called either, Sean, but it's mine. Ours is a 4-limbed suture anchor, and it's a nice way to get to the to also include the capsule, which I think is important. When I first started, I was just doing the deltoid, and I would still see some translation. And when I started including the capsule, it would be much more stable. John, we have about 10 more minutes, so I'm going to skip ahead to the last case and then summarize, if that's okay.
I love it. Keep moving.
Good. So look, I had 4 other cases that showed sort of similar ideas, which are to understand what's injured about the ankle and then sequentially fix each of those areas until you gain stability of the ankle. And if you believe, like the folks at special surgery believe, that anatomic fixation of not just the bone, but of the soft tissues can restore ankle stability, it will significantly decrease the amount of transsyndesmotic fixation that you use in your practice. And we've all heard about why that may be a good thing to do, you know, in other lectures. So again, if you believe in that concept, I'll challenge you to apply it here. John, again, sort of traditionally, you would look at this and you might classify it also as a pronation external rotation injury, and understand that the same structures are injured. Do you have the cojones to manage this the same way?
Well, it's so interesting because the obliquity of the fracture is a little bit different than you'd expect, but I think to have that widening at both the medial clear space and the syndesmosis, you know that those same structures that you have listed are disrupted, and so again, now you're thinking about how can you address those. I think we mentioned this fibular pattern. It's not quite clear. There is some comminution that you see there on the lateral, and so trying to get an anatomic read may not be possible, but again, I think with closer study, you can give that consideration. I think here, this is the interesting thing, and I'd love to hear your guys' thoughts about it in terms of doing any sort of ligamentous repair for the PITFL. Again, I think we'll discuss it shortly, but I haven't had experience with that personally. It's always had an osseous attachment, and so I'm kind of curious if people are finding that to be more common and some of the difficulties associated with that. But again, I think it is possible. I'd say maybe not common for me to treat that when I don't have reliable sites of what I can reduce and stabilize accurately.
Sean, are you going after this fibula?
I am. I like fixing high fibulas. In fact, I think they're more fun to fix. I hate the fibula fractures 5 to 8 centimeters above the ankle joint, where you got to put torsion on a plate because of the annoying perineal ridge. So I actually find these to be these are more fun. Just go on the backside of the perineals, and it's a nice surface, and that way I know I've got that length and rotation correct. And so for me,
and that's your goal, right? I mean, it's still a Weber C. It's just a high Weber C. It's still the same ankle injury, right? I mean, it's sort of is a challenge for me to discuss this with folks that don't think that way, and maybe some of you can help me understand what it is. But it's the same injury that we just looked at, right? It doesn't have a posterior malleolus fracture, but it's just a higher fibula. So the principles to me still apply. You still need to get the length and the alignment and the rotation of that fibula correct for you to begin to get a stable ankle.
Yep, you're definitely preaching to the choir. When I was a resident, though, this was called the junior resident, put a clamp on, put syndesmosis screws across a horribly malreduced syndesmosis with a short fibula, high fives all around. But yeah, I'm a big believer in the fibula in these circumstances.
So we have some questions to answer, and so I'll try to just go through this case reasonably quickly. The structures that are injured are listed. We did what Sean described, which was to do a direct exposure and an anatomic reduction of the fibula. It doesn't have to be a big beefy implant here. It's really just to get the fibula out to length and appropriately positioned. And then what? So now we come down to the ankle and we stress it, and there's instability. And so what's your next move here, Sean?
Deltoid.
Okay, perfect. Deltoid gets fixed, and we have a little bit of a stress view. Is that good? Is that good enough? Do I need to do more?
Ooh,
here's my normal. There's the stress.
Yeah, that looks a little sketchy. The tibiofibular overlap, it doesn't look that different between those, but this is one where I would have had a comparison view of the other side, because I'm not confident that that incisura relative to the fibula looks wide. So I like the medial clear space, but I'm not routinely getting MRIs. I mean, if someone came in with an MRI and told me that the posterior tibiofibular ligament was avulsed from the tibia, I'd have no question in my mind, but we're not routinely getting MRIs. But I'd be nervous about that.
So this right now, if we fix the medial malleolus, the talus is stable beneath the plafond, isn't this just a high ankle sprain? And do you manage those surgically all the time? John? Sean?
I don't treat high ankle sprains. Thank you.
Well, it starts to go down that path, right? Like, okay, I don't like that tibiofibular clear space overlap either. And so I actually opened this syndesmosis and looked at it, and could look directly at the AITFL. And although it was reduced, it was externally rotated somewhat. And so by internally rotating that fibula and then actually putting a suture anchor in to the distal tibia and securing the AITFL, which was one of the attendees' questions, that stabilized this syndesmosis so that it was no longer unstable. And so now you see better tib-fib overlap there. And when we let it ride like that, and this is what he looks like, 6 months later, and he's doing good. So again, I show this, it's a bit of a provocative case. I get it. Maybe this isn't the one that we should be showing the world and saying, this is how you fix this specific injury. But I present it to help people or challenge them to think about ways to fix these fractures differently, especially when it comes to the syndesmosis, because we know that the way that we do it now is imperfect. And perhaps if we thought about managing it more anatomically by fixing each of the individual parts of the injury that we know to be there, we may have better results. And that probably leads us onto the paper as we go. So just take home points for me. When you can, just force yourself to classify the ankle fracture. It helps you understand it better. If you don't understand it, you're going to get a CT scan, right? So all of that goes into understanding the fracture, which you have to do to be able to classify it. So think about classifying your ankle fractures. And then when you're fixing the fractures, repair each individual part of the injury stepwise until you've got stability. So I'm fixing one part, examining under fluoro. Oh, it's not stable. I'm going to fix the next part. Examine it under fillet. It's not stable. Fix the next part. Oh, it's stable. I'm done. So whether that's bone or soft tissue, keep doing it in a stepwise manner. And once you get stability, you can stop. And I think by doing that, you'll reduce the need for syndesmotic instrumentation, which we know in a lot of cases actually induces malreduction and gives people fits. So thanks for your time. Maybe I can go through some of these questions. There's a lot of questions here. Someone asked about the lack of parallelism in the mortise view. That's probably because I hadn't had either the ankle perfectly rotated or the fibula itself was rotated inwards somewhat, and that created the lack of parallelism. That would suggest that the fibula was mal-rotated one direction or the other. And I certainly would not doubt that if it was one of my cases. Would my fixation sequence be different in a diabetic obese patient? Boy, I probably wouldn't do that last case the same way if the patient was diabetic or obese. I would load that person up with trans osseous syndesmotic fixation for fear that soft tissue failure would unfortunately fail in that specific patient population. I do both syndesmotic reductions, both open and radiographic. But if I fix all the parts like we talked about, if I fix the fibula anatomically, if I fix the post-gemellus anatomically, and I get the deltoid fixed, and the syndesmosis looks reduced radiographically to me, I'm done. I don't open it in that stage. Weight bearing protocol, I don't weight bear them immediately. I keep them off of it for about 6 weeks. They're doing weight of leg weight bearing, we call it, and they do come out of their splint and move their ankle immediately, after their soft tissues have calmed down. Clamp, would it be wrong? Someone asked the question, would it be wrong to use a clamp, pull the distal fibula to length to get the rotation right, pin to the talus, open reduction of the syndesmosis, and use screws? I'll let one of you guys answer that. I'm a big fan of getting the fibula out to length. The question says, though I totally understand that aspect. John, what would you say about that? Can you just pull on the fibula and then sort of stabilize it with a wire and put a couple screws across? Does that work?
Well, I think like Sean just said, I think that's where he started, and I think that's where I started as well, and I think just as we learned, there was someone talking about how high do you go? And I have patients where it's been really high, where you do an open approach. And I've just had 2 screws just to hold it, just to get the length, the alignment, the rotation of it is more so some of the problem. I think length sometimes you can pull, but then you don't quite have the flexion extension, you don't have the translation, you don't have the rotation just quite right. And so I think by doing that open approach, like you showed, like I've been made a believer of doing that for those injuries because it takes some of those variables out of the way. And I think I've evolved too, just like Sean said, where you fix that, but then, if you back up 5 years, that was getting transsyndesmotic fixation, not looking at the deltoid. And so again, I think that those things are shifting to appreciate, just like the PITFL. I think that's been clearly shown. Once you reduce that, it's taken away a variable that you can't mess up. I think one of my other mentors, Dr. Rout, says you'll always be amazed of how you can mess things up, right? And so I think if you can take away your ability to induce a malreduction, I think that's the option I'm going to take. And so I think by reestablishing ligamentous stability of the PITFL and the deltoid, just like you showed for both cases, it's diminishing your need to try to do an open reduction because you are reestablishing that relationship of the syndesmosis indirectly by repairing its native anatomy.
Anthony, I'd just say, and I've done this before with the residents, do your technique, pull with the clamp, get the distal fibula where you think it is, pin it in place, and then go up to the fibula where it's broken and look at how it's aligned. And you'll be really surprised at how displaced it still is, and most importantly, how shortened it still is. And some of that comes from the proximal fibula being displaced a little bit as well. But you'll find that if you take that fixation out distally and then reduce it anatomically, your fibula will be in a different position.
Agreed.
There's one other question here, but I don't understand it. Eduardo asks opinion on the lateral transmalleolar approach. John or Sean, are you guys familiar with that? And can you comment about that instead of fixing the deltoid?
Yeah, so I don't totally understand it. I understand some people will use a lateral transmalleolar approach to clean the posterior malleolus, and
Yes.
that makes total sense, because those two fracture planes are often, they go together as a team. But I'm not sure what Eduardo was asking with regards to the part about instead of fixing the deltoid. So I just wasn't clear on that.
Yeah, same. Sorry, nothing to add. I think, Matt, thank you very much. I think those are great examples. I think it nicely kind of blends into the article that we picked, which Sean referenced. And it's this. It's the out of JOT 2015, just anatomic fixation of SER type 4 equivalent ankle fractures. And again, a mix of everyone, like Sean mentioned, from Milton, Marshall, Dr. Schottel, Dr. Helfit, and so on, kind of scattered around the country from LA to Vermont to Boston and New York. And so let's just go through it, probably not give it the full attention it desires or needs or deserves, but you know, this was a paper that looked at just like what we've been talking about in terms of comparing radiographic and clinical outcomes of these injuries, SCR4 equivalent, and we'll get into that diagnosis of how they made it by doing ligamentous only repair of the PITFL and the deltoid, or doing transsyndesmotic fixation without any ligamentous repair and looking at their outcomes. And so their hypotheses are listed here in terms of just doing a ligamentous repair only, and how to compare to the transsyndesmotic fixation is that it would lead to improved radiographic outcomes and decreased need for secondary surgeries, with also a decreased malreduction rate. And so to do this was a 7-year history of their institution from their senior author, who took all ankle fractures and they were in kind of their database. And so it ended up being about 20% of the injuries they saw were the ones that were in this cohort. And so these were diagnosed with preoperative MRIs. And again, I think just like Sean, I don't think many of us are getting MRIs, but for this study, every single patient had that and made the diagnosis of a lateral malleolus fracture, and then just a PITFL and a deltoid ligament tear with no associated fracture. And so each one had the same treatment in terms of algorithm with preoperative and intraoperative external rotation stress, just like I think Matt showed very nicely in terms of sequentially going through and addressing each side of instability. And then in follow-up, each patient had x-rays and CT evaluation to show. You can kind of see here on the right in terms of how they're measuring the reduction. And then they follow these patients at pretty standard intervals, 2 weeks, 6 weeks, 3 months, 6 months, and a year, both clinically and radiographically. And so their technique, very much like Matt just demonstrated, was that these patients were, for their team, were prone with a posterolateral approach. But then again, fibular first fixation, there wasn't a large posterior malleolus fracture. We talked about sequencing. This was a ligamentous repair. So the fibula was repaired first. And then they did do a direct primary repair, and they kind of nicely go into it in the paper in terms of looking at the sleeve and getting a sense of where that is repaired down to. That I don't have. I mentioned I don't have a history with that, but I'd love to hear your guys' thoughts as well. But once the fibula is fixed, there's a rotation stress test. And there are two cohorts for the study, kind of came from a historical trend, I think just like we've both had, or all three of us have had throughout the careers, where the first part of the 7 years, he was treating people with transsyndesmotic fixation, really based upon this test. Stress positive, reduced, held, and then 2 locking 3.5 millimeter transsyndesmotic screws were placed. The last couple of years, his practice pattern changed, and he went to doing ligamentous repairs that are demonstrated here. You can kind of see, again, an image on the left shows the fibular fixation with the PITFL repair, and then there's a stress, and you can see that talar tilt, I think we talked about, as well as people were asking in the chat, but that's the indication for this reduction and fixation of the deltoid ligament, like we talked about. And so again, every single patient that was in this cohort went down one of these 2 pathways. And so the results you can see here, there was a total of 45 patients, really not a whole lot different from the basic demographics, other than more females in ligamentous repair and some increased smokers in the transsyndesmotic. Really nothing to speak more about than that. But the results I thought were pretty impressive. And so when they had primary repair of all the ligamentous structures, you can see that there was only a 2% incidence of malreduction in the syndesmosis. And that's based off imaging, but then post-op CT. And that was defined as greater than 2 millimeters of displacement compared to the contralateral side, which was included in the CT. And so again, a 7% malreduction rate for ligamentous repair versus a 33% chance with fibular fixation alone, and then some sort of reduction maneuver with a clamp or a thumb, and then transsyndesmotic fixation. And so a much higher malreduction rate with the transsyndesmotic screws, kind of opposite to what the cases Dr. Camuso showed us. And so overall, when I look at people over time, really the statistics showed that there was decreased medial clear space at 1 year for the ligamentous repair, but really no difference for infection rate, wound complications, ankle range of motions. Everything was relatively similar between the groups, except for the last one, it comes to implant removal. Again, you can see 11 versus 78% implant removal rate for the syndesmotic screws, and that's multifactorial and probably too much to get into as our time is going down. But I think when you look about summarizing this, the authors, I think, have shown very nicely, and they've followed up with cadaveric studies in terms of the benefits and strength of the anatomic ligamentous repair. And so in this series, they showed a significant decrease in the incidence of syndesmotic malreduction, and also the decreased need for secondary surgery from symptomatic implants for a multitude of reasons. But again, the major limitation they acknowledge is that there wasn't really a clinical outcome that they had. They had range of motion and radiographic outcomes, but really nothing else. They alluded to the fact that there's been multiple studies showing that with the more accurately reduced syndesmosis, you're going to have increased or higher clinical function outcome scores. They just didn't have it for this study. And so again, this was now 6-7 years ago, and there have been studies going forward that have commented on this. And so Matt, Sean, any thoughts to add about this paper? I think it builds pretty nicely on what Matt just showed us.
Yeah, all I have to say is I'm a believer, not only in their results, but it's definitely kind of changed the way I think about ankles for sure.
Yeah, I would agree. I mean, this was sort of an inspiration to me to keep going down the trend that I was going towards. When I first started, I was finding I was putting in way too many syndesmotic screws because I was just finding little minor bits of instability here and there and throwing screws in. And I by doing these things, you know, the alternative methods of stabilizing the ankle, you know, that number went way down. And this study and talking with Dean, you know, really helped me, you know, continue down that path to the point where now I'm pretty confident with the way that we can get good stability without using transcendus fixation in the majority of cases.
Yeah, I like it. So thanks again, both Sean and Matt, for participating and showing those cases. I think we had some great discussion. I think Matt kind of summed up some of his findings from his section, but again, I think back, an hour and 24 minutes ago, we started down this path in terms of really understanding the radiographic findings and what that's correlated with. I think Matt nicely commented on trying to define the injury, understand what is broken, whether it's osseous or ligamentous, and then the sequence about how we can go set up and plan to repair that. I think we've talked a little bit and really focused on what the ligamentous stability contributes to the ankle, both capsule as well as PITF fail and deltoid. And I think, again, that's an emerging concept that a lot of us are following, but something to think about for sure. I think both Matt and Sean nicely showed some cases that showed an algorithm of how to think about fixing these injuries. And just realize that there are subtleties. I think it's not always one. I think we heard about the fibula and the posterior malleolus. It's not always one goes first, right? I think there's times and situations where they're going to go back and forth. And so don't get stuck in being so dogmatic. And I think, again, we talked about things and ways to think about fixing fractures. And I think it'll kind of lead us to more of a best practice approach in the future. And I think it's all evolving. Again, I think we've always seen that our cases, if we look at them from 5 years ago, 10 years ago, we sometimes kind of cringe because it's different than what you do now. So I think that's the beauty and why I love my job so much, is that we're always learning and always evolving. And so I think it's been great to always reflect on this and try to learn it and keep going down the hole, just like Matt was talking about. And so with that, I think, at the very beginning, we mentioned this is the first. We have 7 more. You can see the topics and dates as you see here. There are some emails coming out. I think I saw one today for the geriatric distal femur. But again, pay attention. There will be emails to sign up and please come back and keep engaging. I think it was great to engage and look at the questions. I apologize for the ones we didn't quite get to. But that's a good thing. And so thank you again for participating. We have just a minute. I think Chris is going to put up a questionnaire. And here it is. If you just take a few minutes to go through and answer these, we'd greatly appreciate it. And then we look forward to seeing you next time. So again, Sean, Matt, thank you very much. Mitch, Brett, thanks again. It's been really fun.